All right, we're ready to start. Good morning, everyone. It's really nice to see you here. Help yourself to coffee and bagels. We're here to share with you a new publication from the Lancet series on NCDs and economics. And I'm Rachel Nugent, and I was the lead of that series. And we have a whole morning. We're going to do a deep dive into NCDs and economics. There's almost nothing I'd rather talk about, so I had to plan hours to do it. So thank you for joining us. And I've kind of conceived of this as a three-course meal. We're going to start this morning, our appetizer, as it were, as a dialogue between myself and Dean Jamieson, Emeritus Professor of Global Health Economics, or Global Health maybe, at UCSF. And you have bios that I hope you picked up out front. A mentor to me and to many other health economists. And we'll talk a little bit about NCDs and economics. And then we'll move on to the main course, which is to talk about the 5 Lancet papers that were published about 2 weeks ago by the Lancet, launched at a large conference in Copenhagen, a conference convened by the WHO and the Danish government on NCD financing. And we had a very good launch there. There's been a lot of press, a lot of Twitter and social media, and some real mainstream media attention to it as well, for reasons that I think will come out as the presenters discuss the papers. And then we'll finish up. Our dessert will be a panel of experts on NCDs and economics and health systems that will talk about what does this Lancet series mean and what does the broader evidence that's being assembled around NCDs in this year of the UN high-level meeting, this year of the WHO high-level, everything's high-level, isn't it, in this world, high-level commission on NCDs, the Bloomberg Summers Task Force on Fiscal Policies for Health, a lot of things happening around NCDs, other things that I can't even remember, that probably some of you are involved in. So that's the run of our show. That's our meal that we're going to have. We'll have a couple of breaks for coffee, but also we'll have time to interact with you over the course of the morning. So I hope that it feels that the pace works for everybody. We are on live stream, so we're using mics, and we'll have roving mics for our discussion and maybe even questions coming from the live stream. I don't know how that works, but they'll let me know. So with that, I actually I have questions here. I have to use my notes to ask Dean questions because I wanted to get some questions that perhaps would make him think a little bit. But everything makes him think. That's not. Dean has been called the preeminent health economist of our generation by the Lancet, and I know that probably embarrasses him a little bit. But he was looking at NCDs before they were called NCDs, and in fact, I think he dislikes that term, as some other people do. So he may have some comments on that. But let me start off with the questions, and then we'll come to you. So, Dean, Dean is an author on Lancet paper number 1 that you have in your hands, but I'm not going to ask him about that. Actually, I'm going to ask him about his work over a series of generations of disease control priorities. He's the mastermind behind the Disease Control Priorities series, which was first published in 1993, and the first one became the World Bank Development Report 93 on investment in health. And I'd like to ask him, first of all, maybe to say a couple of words about, what was that moment in time when investing in health was published. There was a DCP2 published in 2006, and then DCP3, which was published between 2015 and 2017, in which I was quite involved, and again, Dean was the leader. So the question is, what have we learned since 1993, and even since 2006 about NCDs and economics, and understanding the place of NCDs in the health of developing countries? What have we learned?
Well, before I turn to the question, I really should congratulate you on this series.
Thank you.
And the reception to it. It's been really quite a remarkable reception. And I know it's been a long journey, as many of these journeys are, getting that from inception to completion. But congratulations, Rachel.
Thank you.
It's really great. As you said, I've been interested in NCDs for a long time. I was the World Bank's first health project officer for China, and in the 80s, quite a while ago. And the Chinese problems at the time were already dominantly NCDs, a slightly different pattern of NCDs than in the West, more in the way of stroke, less in the way of heart disease. But nonetheless, that was dominant in the epidemiological profile of China. And there was very little attention at the World Bank, very little capacity at the World Bank for thinking about responses, nor at WHO, nor as I perceived it in academia. So it was the inception, really, of the first iteration of disease control priorities was around thinking of responses that would be affordable at a population level to the NCDs, also to the emergence of AIDS. So there were those 2 points of genesis in the context of an incomplete but nonetheless enormously successful program of work against childhood infection. This was clearly had to remain the dominant priority, but the other issues couldn't be neglected. So that was the origin of the interests. And you asked a little bit about what's changed. I remember having a conversation with Sridath Reddy over lunch in Delhi not too many years ago, but what I was wondering was how much change there's been in the recommendations around cardiovascular disease from the chapters in DCP-1 published in 1993 and what we're saying today in 2017. And my sense was that around response to acute MI, medical approaches to secondary prevention, primary prevention mostly through control of tobacco use, that the messages of 1993, almost to the detail of the drugs, not quite, were the same ones we were conveying today. So there's a great deal of continuity. What was enormously different was, and Srinath knows this very well, as the rest of us, there was almost no interest in the 1990s in these questions, despite the evident epidemiological numbers, demographic numbers. And that has changed for sure.
In China, I'd say very much so, what I hear, and you work in China much more, there's an almost to the exclusion of anything else, it seems like, attention to the NCD burden.
Yeah, I believe that's true. I am a little bit distant from China. They continue to have a dominant problem with stroke. It's quite relative to heart disease and other NCDs. So they really have a huge problem to deal with. And certainly the infectious diseases aren't behind them or really anybody, but it's quantitatively really much smaller issue in most, but not all of China. So it's an appropriate transition. But what I was referring to was the degree of attention that we're seeing in this Lancet series. In other Lancet series, you've noted several times that there are quite a few activities going on preparatory to the UN meeting and independently of it. We didn't see any of that kind of interest, I think, 20 years ago. So there's an analytic and economics attention, technical attention that was absent 20 years ago. And that's real progress. It's only the beginning, but that's, in my view, real progress.
I guess that leads well into my next question, which is if you were to do something differently than what you did with DCP-1, DCP-2, or even DCP-3, and I refer people to that if you haven't seen it, dcp-3.org. 9 volumes, there's lots of reading for you there. And NCDs, just to put an underscore on what Dean just said, NCDs have not just a chapter, not just a few chapters, but there's a volume on cancer, there's a volume on mental health, there's a volume on cardiovascular, respiratory, and related diseases. Did I catch it all? I think that's largely where NCDs show up. And then there's a final volume on UHC and packages and so on. So it's really quite a strong body of evidence. But I want to ask Dean, would you do something differently during the course of the DCP multi-generational output around NCDs and economics?
Well, Mostly when you're working with around the responses to a specific disease, you're working with people who know a lot about that disease. And those tend to be people who care about that disease, who are advocates for programs for control of that disease. Those people, in my experience, find it very difficult to identify the main and often long list of things that are very low priority, the things not to do. And the list of things not to do in the NCD domain is really quite long, particularly around cancers, but certainly heart disease, mental health as well. So I think if I were redoing the NCD side of our work over the last 15 years, I would put a lot more pressure, a lot more focus in the conversation on what not to do as a mechanism for sharpening the spotlight on what does need to be done, what could be very productively done. I think actually we've tried, and you made some very good efforts, I think, around the cardiovascular disease agenda. Actually, one of the cancer chapters in the second edition was quite good about things not to do. But as a general rule, I would push much harder on that, and I think that the disease communities should pay more attention to that themselves.
And I would add my own comment that the advocacy communities, in my view, have a responsibility to pay attention to what not to do. Because when you present policymakers with long lists of things to do that sort of seem never-ending, and I think maybe this is at the core of some of our difficulty in getting our NCD messages out, it seems overwhelming. And it is a big problem, and it can be an expensive problem to deal with, but the benefits are high. But I think that they can lose track of the fact that you get high benefits when they get overwhelmed by the immensity of things to do, and some of them aren't cost beneficial. So I think we tried.
I think one example of what I'd call partial success in DCP3 around the trying is that when we attempt to add up the cost across the full range of interventions that we recommend be a starting point for discussion, some what we're calling essential UHC, 218 interventions. And we have costed the packages, including the cardiovascular disease package, that go into that list, and we've costed the whole list. And two things about that. One is even though we paid a lot of attention to trying to generate a notion of UHC and a notion of the highest priority parts of UHC, the price tag is still just too high. We tried. We're going to have to make another pass at it because it's still too expensive. Several percent of GDP in lower middle income countries additional through the public sector, and that's maybe as a long-term aspiration, something that's reasonable to do. I'm convinced it is, but that's a big ask. On the cardiovascular disease side, I forget at the end, but it's almost half of the total, and that's not in terms of the way we're being received in EUHC, in our advocacy for EUHC. That's too much, relatively speaking, for the CVD side. So I think we do have to, even though we paid, and I know you personally paid a lot of attention, some of your co-editors didn't, but you personally paid a lot of attention to this question. It needs a harder look.
Great. I'm going to ask one more question and turn to the audience. And my question, I've already referred to the many pretty, high-level activities that are happening this year in preparation for the September 27th, I can remember that because it's my birthday, September 27th UN General Assembly meeting on NCDs, and a flood of studies and reports and attention that I think those of us in the NCD community have been preparing for and anticipating for quite a long time, hoping that 2018 will be something of a turning point where we can see more action from both global and country-level policymakers. I think that it's quite widely acknowledged, not just in our community, but among others in global health and even in global development, that the NCD burden is quite disproportional to the attention and the funding that it's gotten. And I heard that 2 weeks ago from the development secretary in Denmark and in Switzerland who were at this meeting, and others that are paying attention and realizing that there's a disproportionality. So I want to, I guess, throw you one more softball, Dean, and ask, do you think we have enough evidence to go to that meeting in September to see something more than just declarations about how to deal with this problem?
Well, at one level, I think we have known for 25 years some of the basic important things, the drugs around prevention of cardiovascular disease, responding to acute MI, the vaccines for a few of the cancers, several cancers, but only a few cancers that are treatable at reasonable cost. So we've known those answers for a long time. There's a longer-term agenda of extending the list somehow of attractive interventions. I mean, the kind of spectacular advances we've seen around drugs against infection, diagnostics for infection, we haven't seen. And maybe it's just because it's we're on the flat of the curve, we're not going to see it. But that would be one missing element, but the core element of how to proceed. I think two things are missing, one of which is substantially addressed by this series, which is the underlying economic and policy argument. I think it perhaps needs to be turned into a tighter or a multivalent policy document or set of documents for different audiences, but that has been incomplete so far, even though we've known some of the interventions are reasonably, not highly, but reasonably cost effective. The second thing I think of that is needed, it's not going to happen for September, but needed in the medium-term future, I think it was kind of the contrast between people doing social science research and military product development. And people doing social science research have more limited budgets than people doing military product development. And one of the consequences of the limited budget is a lot of attention to the power of a design. And they have sample sizes that are closely calculated to minimize the required sample size, to minimize the cost of the enterprise, and always then you get t-values that are 2.00. It's marginal. They're just taking the minimal step often on the pressing it. The military is up in general, for better or for worse, over-designed very heavily. They try to make the next product really a lot better than the last one around. Without too much attention to cost, the cost considerations do have to come in, but they're more in the way of taking back as efficiently as possible. What does that mean, I think, for the work that this community, this larger community, do? I think we need very large-scale, but not at scale, implementation trials of alternative approaches to implementation that involve the whole range of human resources, training in the medical schools, long-term 10-year activities that you'll be learning from year one, from the baseline studies, but continuing to learn from what really does work in certain types of environments to get the doctors to be doing the right thing. Once the doctors are more or less doing the right thing, to generate the adherence in the populations, making what makes it easy. Easy access to drugs. Do you have to get your drugs every week, or can you get them every month? How far do you have to go? We know a lot of the questions, but to have explored on the ground in many different contexts what the answers might be, that'll be expensive research, but it'll have medical health payoffs along the way. So it's not a gross cost, it's a net cost on top of the benefits. But I see a really missing agenda there that maybe for the next high-level conference, there'd be more in the way of of not, these are the kinds of things that can be done. We have a list of interventions that we know that work, which we do, and at reasonable cost. We have a list of implementation experiences that we have shown can be made to work in this kind of environment and that.
Great. I'm sure that there are a number of researchers here and online that are happy to hear that there's a good long agenda that needs to be done, and I completely agree with it. Let me turn to you in the room and online, if I can figure out how to do that, to take advantage of Dean being here. I'll be here all morning, so Dean has to catch a plane. So mostly this is for Deans, and invite some questions here first. And if you'd introduce yourself and your affiliation. Thank you.
My name is Bradley Randall. I was recently affiliated with Partners in Health down in southern Mexico and southern Africa. I guess I have two quick questions. Can you make reference to renal disease, kind of especially advanced renal disease, and kind of what you see happening there? And then in terms of cardiovascular disease, can you make reference to any countries that you could give as success stories, where, as in the U.S., we have seen some victories over the last generation? Are there any other developing countries you could say are moving in the right direction?
I'll take another question, and we'll come back. Dean, Christina?
Thank you. Christina Ravadan-Deal from the Department of Health and Human Services here in the U.S. I'm the Director of the Americas, but a long-time NCD advocate. So my question really relates to some of your comments, but I'm interested actually in your input. So this is about the investment, so the funds or the resources that need to be behind us to move that curve on NCDs. And we know that in the infectious disease, particularly with HIV, there were large programs that brought a lot of money, the Global Fund, PEPFAR, that really have changed and moved the needle in the right direction, making now HIV a chronic disease. So when we think about, the UN summit coming up and trying to go beyond these declarations, high-level declarations, we also have to be very cognizant that these diseases really spanned the political life of the people in leadership. So who are the people that we actually need to engage in order for that to survive? Because when we think about the investment, there's now a push of this being country-owned, that the agendas of the countries should not be pushed by the donors, but rather by the needs of the countries. Are we engaging the right interlocutors? Are the ministers of health really our right interlocutors, or should we shifting the argument and the partners in a different direction?
Thank you. So in whichever order, and
okay, so remind me if I
renal
miss
disease,
something, because my
renal
memory.
disease and CVD successes.
I would really be inclined to turn the renal disease one over to you. You've thought much more about that, but obviously end-stage renal disease poses a particular set of ethical and economic and human problems that I don't think have an easy resolution. There are approaches to dealing with it, and Rachel, I know, has spent some time thinking about that. Countries that have done well outside the high-income countries, and so a lot of the high-income countries, as you alluded to, have done actually spectacularly well in reducing mortality from heart disease and stroke. It's a relatively unnoticed social success in many, but not all, high-income countries. Low-income countries, I went through an exercise mostly for the Americas recently, and we're redoing it now, of looking at the rate of decline over the period 2000 to 2015 of mortality and mortality rates from ischemic heart disease. And I'm afraid what I remember better are the, to me, striking negative findings. So you have a list of those that had the fastest rates of decline. The Netherlands was, I think, the fastest. Israel was another one. There were two large countries that had rates of increase, not just in deaths, but also in death rates, and those were India and China. So India, maybe not a surprise. China, a bit more of a surprise. We were working on this in the particular context of Mexico, and from the work I had done previously on Mexico, I had expected Mexico to be quite good, and that wasn't true either. It was down near the bottom. And so that's not answering your question, that we have the list at the top. There were certainly some low and middle income countries that were achieving rapid rates of decline. Quite why, we don't know, but almost certainly it was importantly because of appropriate policies in the health system. On the question of communities to address, with the long-term perspective that I think you correctly point to as important, the DCP has had some experience and explored some different approaches, and we haven't, I think, collectively come to any judgment about what has worked best, and partly we can't make that judgment for another 20 years, but what appears to be working best. And the standard approach, which we've taken for the most part, is that we have a public health community in schools of public health and epidemiologically oriented faculty members in oncology and cardiovascular disease. And we work with the public health community and the healthcare system. And I think we can't, it's totally unreasonable to expect widespread rapid success. But if you have a few moderate successes, and I think we've had those, that's would be an indicator of real progress. The other approach that we've taken is through our advisory committee in DCP, and particularly this was true in DCP 2, was constituted by the International Association of Academies of Medicine, the Inter-Academies Medical Panel, and that brings together the elite clinicians, each country's, the elite clinicians and the elite medical scientists in the country, and people from those communities joined us. And my own impression was two things. One, we got a lot of very sharp advice from these people, because they're, on the whole, pretty smart people. And they paid a lot of attention to what they were doing. They weren't just saying, well, it's public health, so obviously I can do it, which is sometimes a scientist reaction. But they took it seriously. And that they, in many cases, had very important contacts in their own governments from their clinical positions or their scientific prestige into the political leadership that a minister of health or a dean of a medical school even, or a dean of a school of public health didn't have. So my sense was that it was very good value to deal with the medical and scientific elites. But I think quite a few of my colleagues just plain disagreed with that, so I'd say that's, to me, an open question.
I'll come to your question about renal disease briefly by telling a little bit of a story. This is, obviously, it's a very expensive thing to treat, and it's growing. Kidney disease and end-stage renal disease growing very fast in a lot of places that don't have the resources to care for it. We were asked by the World Bank and the government, the development agency in Australia, to help out a small island country that I won't name, but they were struggling with the fact that they have very high rates of diabetes, very high rates of renal disease, and they were sending the population in need of care offshore. This is not an unusual solution for many countries that don't have the technical medical facilities themselves. It had come to their attention that it was getting very expensive, and I think it had come to their attention because a vendor from another country, from a large nearby country, decided to try to sell them on the idea of building their own dialysis center. So the Minister of Health was pretty sure that that's what he wanted to do, because it was popular among his population. We won't send people away anymore. They'll be able to stay here on island. We'll take care of the problem because we are going to provide for the health of the population. So we were asked by these outside interests who had invested a lot in the health of that country and that population to do an economic analysis. And perhaps not too surprisingly, although, until you do it, you don't know the answers. it was not advisable to build the dialysis center on this island for a variety of reasons, not just in terms of the cost-benefit analysis, which we did, but there were environmental implications of needing that much water. There were implications about the insufficiency of health workers. And there were a number of issues that, over a period of time, maybe not even a very long time, would become real binding constraints. So we offered that, along with the advice that, of course, if you concentrate more on prevention and work more on obesity and diet and try to slow the progression of diabetes and identify people at the stage of pre-diabetes, you're going to, save a lot of money in the long run. Bottom line was they built, they're on the way to building the center on the island. I think that decision had sort of been preordained. Even the funders of our work knew that. I think maybe a little bit of a silver lining there is that it did highlight for the Ministry of Health that they should be doing more on prevention and more to pay attention to the earlier stages of the disease, and perhaps they were feeling some real pain points around this and would continue to feel the pain points around the cost of treating people. So I know that kind of situation is happening in a lot of places, and Dean is right to say this is also an ethical issue because, quite clearly, Thailand, and I'll wrap up with this, Thailand is an example where they have done very extensive priority setting, well informed by health technology analysis. HITAP in Thailand is the world's preeminent, I think, aside from NICE in the UK, agency for health technology analysis, and uses it very seriously. And they made a very explicit decision in the course of developing their NCD service package that they are going to provide hemodialysis for everybody that needs it. They knew it would be expensive. And they said, well, we'll revisit this at some stage, and it has turned out to be even more expensive than they thought it would be. But that was, the process they had was quite transparent, quite deliberate, quite evidence-informed. So, I think it's a great example. All right, I am going to wrap up this appetizer. I hope it's whetted your appetite for more discussion about NCDs and economics and hearing about the papers and more than that, the agenda and how we hope this will contribute to the agenda. I want to thank Dean for staying long enough to, I hope not miss his flight to China, but to join us for this, to share a little bit of his experience over some decades of thinking about NCDs before I was, certainly before many of us were, and sharing your experience and findings, because I think there's always much to learn from you. So thank you very much.
Thanks for the opportunity.
Thank you again for joining us. I'm going to see if I can kind of perch and sit at the same time. Both here in person and online. Thanks for joining us for the main course. We have a great panel of authors, and I think I've just coined a term, I don't know if it'll stick, but we don't have a WANL. That would be a woman-only panel. And so I'm delighted that Kofi's here so that nobody can tweet about us in any negative way for having a WANL. But there was, as many of you know, there have been many tweets about manels that happen, and so I don't want to go too far in the other direction, but I kind of like the balance, don't you? All right, so this is about the Lancet series, and I'm going to give you a little bit of history and background and the motivation for doing this before we turn to the individual papers. But when we began to prepare this series in the Lancet, we really didn't imagine, first of all, we didn't imagine that it would be launched in 2018. We didn't imagine that we would launch it, as we did 2 weeks ago in Copenhagen, at a meeting on NCD financing, and that turned out to be really a great occasion. It was a very good dialogue about the needs, the financing gap for NCDs, where the money should go, what are cost-effective interventions, what are the activities that people have underway and what are they trying to learn in those activities about addressing prevention and care of NCDs, and where will the money come from. And there were actually a number of announcements about funds from funders and donors. We hadn't necessarily anticipated that, but there are clearly some donors that, as we all know, I think, that have been watching this space, in some cases actively funding, and we'll talk a little bit later on about some of the funding research that we've done and what we've found. So it was a very fertile ground for talking about NCDs and economics and financing. And so is this, a community that's very knowledgeable, I think, here in Washington with the NCD Roundtable and the Global Health Council activity on NCDs and many of the other organizations that you all are affiliated with, and people on the line as well. And NIH, I want to recognize the long time funding that NIH has been providing for research into NCDs. So it's really nice to be here. And maybe there are some people who are just curious about this and why it seems important to global health. So the history of the work, there's a fellow named Robert Beaglehole who was a director at WHO, and with his wife Ruth Bonita, they began the NCD Lancet, and with Richard Horton, of course, the Lancet Action Series on NCDs. And the first one of those, there have been 4 prior Lancet Action Series on NCDs. I have to look at the dates or I will forget. 2005, 2007, 2010, and 2013. So before NCDs were called NCDs, and subsequent to the 2011 meeting, on different aspects of NCDs. And the last one was on, I was a part of it, I think it was probably Srinath, you were too, on sustainable development and NCDs, if I recall correctly. Sir George Elaine was a part of it, and a number of others. And after that, Robert Beaglehole issued a query to people who'd been involved in some of these Lancet series and said, well, what should we do next? What else is needed to make the case? What other kind of evidence it needs to be brought to the forefront? So I have long felt that my own discipline of economics had done a lousy job of conveying what we knew and identifying what we still needed to know about the economics of NCDs. Oftentimes what I saw was that there would be very confusing in the sense that you could find an estimate here that said one thing and an estimate there that said something else, and are things cost effective or not? Well, a lot of it is context dependent, but we hadn't done a good job of communicating what we did know. And so I suggested that we ought to have a series on economics and financing, and much to my surprise, both Robert and Richard thought that was a good idea to put that in a Lancet. So what we've tried to do is, these are review papers in general. There is some original work that was done for the investment case and for the price policies paper, and you'll hear about both of those. But a lot of them are reviewing what the evidence was and trying to make it understandable. And also, and my big push was, let's not do this on the one hand this, on the other hand that I think it was Harry Truman said economists are always doing to him. He said, I want a one-armed economist who doesn't tell me that it could be this, it could be that. I want to kind of know what I'm supposed to know. And so that's one thing we try to do. And I think we did succeed in having quite clear and forceful messages come out, which you'll hear in just a moment. Richard Horton, and I need to acknowledge Richard, who I think probably most people are familiar with his influence, his ability to make matters seem both important and pressing, and motivate people to move the agenda forward when it comes to research and policy. And Richard was very much behind this, but he did tell us when we thought just about finished with our papers, they're too economicsy. You've got to take some of that economic stuff out so that my readership can understand them. And you also, by the way, need to produce a whole new paper to connect the NCDs to the SDGs. So that was after the SDGs had been agreed, and we had started before the SDGs had been agreed. So it was a little bit of a curveball for us. But that's paper number 1, and I'll talk about that in just a moment. But Richard did more. He made us a task force We weren't exactly sure what a task force was, but apparently task forces are popular these days. So what he did, and this does have the title, Lancet Task Force, so it's not a mere Lancet series, it's a Lancet Task Force, and with that he intended that this work and our collective effort, and there were many, many authors involved, would continue to inform the policy discussion around NCDs and economics. And he did what Richard does and managed to make us an official partner of the WHO High-Level Commission on NCDs that is underway right now, led by Sanya Nishtar, and we'll have a report in June about NCDs that is intended to inform the UN high-level meeting. So he's made us an official partner, and we are trying to help the high-level commission perhaps have some economic and finance wisdom in their report. We'll see how that goes. He also invited and got really very strong commentaries from Dr. Tedros, from Larry Summers, the head of the Task Force on Fiscal Policy for Health, and himself and our editor Jennifer Sargent, who all put comments in here about the importance of this moment. So with all of that background introduction, I'll stop finally, and let me tell you a little bit about paper number 1. That's the urgency thing that came from Richard, and a little bit about paper number 1. So the challenge put to us by Richard for this paper was to explain the connection between NCDs and the SDGs. We all know that NCDs had not been part of the MDGs. When Richard put this challenge to us, it was the SDGs were still quite new, and we have a target as part of SDG number 3 to reduce NCD mortality by 1/3, premature mortality by 1/3 by 2030. And he said, tell us, first of all, how is that going to happen? And secondly, how does that relate to this whole set of other SDGs? So that was rather a big challenge, and I think to point number 1, as you'll see when you look at the paper, figure number 1 shows that we are not at all on target to meet that SDG 30% reduction of premature mortality. It is, I would say right now, highly unlikely, not impossible, but highly unlikely that target will be met. And I think that's important to know, and it's important to take that and to understand why not. One of the reasons why not is that when you look at figure 1 in the paper, you'll see that there's a great disparity between what's happening in higher income countries compared to what's happening in lower income countries. The high income and the upper middle income countries are seeing really high rates of mortality decline from collective NCDs. They're doing quite well. And at that rate, we're totally on track. No problem. When you look at the low income and the low middle income countries, it's a very different story. There is a decline in the mortality rates, so it's the right direction. But as I think they often say in DC, right direction, off track, or right direction, wrong track, or something like that. So what's happening, unlike in other areas of global health, infectious diseases, maternal child health, and so on, where there is a convergence, that is, that lower income countries are starting to get, well, not starting to, are getting closer and closer to the levels, the mortality rates of higher income countries, and happily so, thanks to the MDG period. In this respect, NCDs, particularly CVD, we're seeing a divergence and increasing inequality across the globe. So I think that's very important, and I think paper 1 puts that front and center. Paper 1's an overview paper. It doesn't delve deeply into the numbers, but it presents them in a way that I think is usable and convincing. The other thing is this connection to the SDGs. And the SDGs are, we're much derided, I think. There's so many of them, and I can't even remember how many targets there are, 17 SDGs, 181 targets, or something like that. But we do have an NCD target, and when you take a look at how the NCD target connects up to targets for other SDGs, and that's what this work does. It wasn't original by me. It was originally done by UN DESA for the SDG discussions, and what they did was they searched through the wording of the targets across all of the SDGs and said, where do we find words that connect up these SDGs? Because the whole idea, of course, is that there is this interlocking set of goals, of global goals, and that when you push in one area, it should influence other areas. It should influence for the better other areas. When you achieve progress in one area, can you simultaneously achieve progress? Or are you inadvertently doing harm to other areas? So what we wanted to do was to show, and again at a fairly high level here, take the work done by UNDESA, where you can see the lines and you can see the little numbers attached. It shows the strength of the connection between targets for those specific other SDGs, not all of them, because there wasn't an identified link for all of them. I think you could probably think of it if you tried really hard. I didn't try really hard. I said, let's take the ones that are the lower hanging fruit, and let's look and see what those connections are and how strong they are, because those are communities that we should be working with. And I think it's not hard for any of us in this room that think about NCDs to realize and to know that NCDs are linked to poverty. Paper number 2 will describe that in detail. NCDs are linked to nutrition, malnutrition of all types, I have to add, as we know. They're linked to gender, and the list is there. They're linked both causally in both directions and in association. We haven't tried to prove causality, but just one example in the paper, if you look at air pollution, and you look at where air pollution, indoor air pollution especially, household air pollution, comes from. It comes from poverty, from burning biomass. It affects particularly women and children negatively. It affects their health very negatively. We want to address that as part of an NCD target because it is a very high burden, respiratory diseases. If we also have sustainable cities, if we have achieved some of the environmental goals of the SDGs, we will help on that front. There are ways in which we can help each other, and I've been involved a little bit in a UN foundation effort to do an investment case for household air pollution, showing the benefits and costs related to NCDs as well as other benefits and costs. They've made that connection, and they're making it very explicit and quantified in the investment case effort. And the World Bank's done a lot of modeling on that as well. We could go on in this room with examples. So that's the point of paper number 1. We made the picture. Richard was satisfied. He said, yep, that shows that NCDs are pretty central to a lot of SDGs, and we can go out and we can talk about that to different communities. So that was essentially my goal with that paper. And once that was done, we could actually go launch the rest of the series, which had been ready and waiting. So I'm going to turn, each of the panelists will spend a short time giving you the high-level messages of the papers. I want to say each of our panelists, up until our man, happily, who's there, are co-authors on the Lancet papers, very deeply involved in the preparation of the Lancet papers. In Copenhagen, we had the lead authors for all of the papers except one person, paper number 2, that Tracy's here representing. The lead author got stuck in Nepal, wasn't able to make it to Copenhagen. But we had those authors, and we had a very good lunch, and I am delighted that we now have a set of marvelous co-authors who have as well very strongly contributed to the series and to the thinking in this area. So I'm going to handle this unless you want to. Tracy? Do you want to?
I do, actually.
Oh, okay. You do it then. Go, girl. And I'm not introducing people because you have bios, but this is Tracy Quelmus.
Colmus.
Colmus.
It's so challenging, I know.
Better if you
it's
introduce yourself,
really
isn't it?
challenging.
Okay.
So I'm Tracy Pettis Colmus from the Uniformed Services University. And for those of you who knew me in a previous incarnation, I was the head of the Health and Family Planning Program at ICDDRB in Bangladesh and functional PI of the Center for Control of Chronic Diseases in Bangladesh, through which paper number 2, ta-da, was conceived and done. So I think it's important because I know that many of our network are either in the room or listening in via live stream today. So I'd like to give a shout out to my Global Health Initiative colleagues across the planet, and also to our generous funders at NHLBI and at the United Health Group. So this paper was conceived initially as a systematic review. So the work focuses on establishing the links, the inequality links between household poverty and non-communicable diseases and their risk factors, primarily, actually exclusively, in low and middle income countries. I think if you're in this room, or especially if you're listening in on the live stream, you've already made that leap of faith that it's not maternal, child, or infectious diseases that are killing the lion's share of people on the planet, that indeed it is non-communicable diseases that are impacting households. And what we wanted to prove is that it was non-communicable diseases that were impacting development and building a bright future in low and middle income countries. So we conducted a systematic review. I'll talk about that in detail. But when we joined the Lancet series rather late in 2012, thank you for that opportunity, Rachel. I'll always be so grateful for you to making the perfect home for this large piece of work. And if there's any systematic reviewers here, you know the challenges of getting a systematic review into a format where it's read widely. So outside of the Cochrane Library or the Campbell Library. So we were asked first to filter the paper through the MDGs, and then as time went on, we went back and we booted it up again through the Sustainable Development Goals. And as you can see, the inequities caused in low and middle income country households are linked strongly to reduction of country inequalities, to gender, to education. The links between health and education and poverty are actually very well established and recognized. We didn't need to prove that. What we wanted to go out and demonstrate is that there was a literature. What did the literature tell us was taking place in households in low and middle income countries, and thus in the populations? So we went out there and we did a literature search, because that's indeed what you do with a systematic review. And we found 283 papers. And I know that for people who are not systematic reviewers, your eyes may glaze over now. I completely empathize with you on that systematic review is just not necessarily thrilling. But of these papers, you can see over time what was taking place and the quality of and the distribution of studies and the quality of those studies over time. We found 287 papers, 283 of which were quantitative in some fashion. And whereas you're never going to get a little forest plot from such homogeneity in the types of studies that we included, what you will see in the graph is an increase in the number of publications that were produced each year, and that amongst these, many of them were like survey. I actually think the next slide is better at explaining what the literature tells us. There's very few studies, perhaps less than a dozen, that would be considered rigorous. The lion's share of them are cross-sectional studies, that D5, it's the sort of the middle box behind, over Rachel's right shoulder to your left, where you do see sort of the lion's share of studies being done. Many of those cross-sectional studies were sponsored by the World Health Organization through the WHO STEPS models that really targeted for the first time non-communicable diseases. So you see both an increase in the raw number of studies that were being conducted looking at non-communicable diseases with risk factors or outcomes of NCDs, but also a link to inequality through SES at the household level. So it's actually, we couldn't quite show, and if you look at the colors, show the direction of the association. Of course, with the systematic review, you can't necessarily, and with cross-sectional studies, with that quality of evidence, you can't prove causality. You can only discuss the association and the level of the association. But there's definitely an association in households and LMICs between poverty and the non-communicable diseases. So if you had doubts that this was real, You don't need to have them anymore. And I think that in this audience were people who did not have those doubts. So we are the collective, agency for getting this message out. But I think it's a message that there's others on the planet that require a task force to come and tell them it's not just about pregnant women and children under the age of 5. That's not what's stopping your nation from transitioning from a low-income country, perhaps, to a lower middle income country, or moving up the economic development phase. If there's anything I think I've got one more slide. Nope, I do not. So I will stop talking now and answer your questions later. But what we hope to have demonstrated is that as researchers, more research is needed, but also to talk about what type. We may have surveyed this issue to death as a body of global health scientists. We might need some cohort studies or from some case control studies, but we hope that the action exists to both get these developing country decision makers and funders to focus on non-communicable diseases in their countries. And I'm going to end with that and hand this to you. It's the other Tracy.
And before we go to the other Tracy, I want to underscore that we brought this paper in. I saw it presented at a conference, and we were pretty far along, and I said, we really need this because we need to understand the link between poverty and NCDs. For certain audiences, and I had very much in mind, of course, the donor community, the sort of global health community, which, had pretty consistently said, that's really a rich, old, white, male person's problem. And we needed to show that, in fact, it's everybody's problem, and I think the paper does a really great job of that. And just yesterday I was at a meeting, and the head of the Gates Foundation Global Health Policy Group asked exactly this question: what's the link to poverty? And again, I think, as Tracy has said very nicely, a lot of us in this room have seen it with our own eyes. If you're working in different countries, range. I was in Copenhagen. There were people from Benin there, from Benin, said that is our biggest problem. In Benin. So it's in Bangladesh. It was shown long ago. So, without trying to over-exercise the data, I think that the paper is really important for showing us that the quality of the evidence for this association has grown, and the amount of evidence as well, and that's important. So with that, the second paper in the series also digs into this effect on households, and I'm going to ask, we have a dynamic duo team, Tracy Laba and then Beverly Esu, who will share the delivery of paper number 2.
Okay, thanks.
I don't know what
Do I
happened
need
to
the
the clicker.
microphone, or- Oh, we've got the clicker.
Oh, okay.
We can click.
Okay, click away.
Great. So thanks very much, Rachel. It's been such a great opportunity to be involved in the series, and thanks for hosting us and giving us an opportunity to chat about our paper. So far, much of the discussions about the economics of NCDs tends to focus at that macro or population level, but it's important to realise that NCDs are affecting individuals, and so too the economic circumstances of the household. This is important not to overlook because, as we know, in lower middle income countries, there is a very high burden of NCDs. There's low levels of financial protection, but there's also an ongoing reliance on user fees to pay for essential treatments, including NCD treatment. We also know globally that high out-of-pocket costs for healthcare mean that many people will forgo necessary treatments. Some people will even forgo basic needs such as food and electricity, housing. So we took a slightly different focus and we looked at the microeconomic impact of NCDs on households. Particularly, we were looking at the adverse economic consequences of NCDs on households in lower middle income countries. And then we considered what this meant in terms of designing financial protection programs, which Bev will talk to you about. So what did we do? We also did a comprehensive literature review. We identified 66 studies that met our inclusion criteria. We found that the rates of financial catastrophe were quite varied, but over 60% in cardiovascular diseases, stroke and cancer. We also found that health insurance lowered the risk or lowered the odds of financial catastrophe by 2 to 7-fold, but it definitely wasn't the panacea for financial protection. For instance, in China, in the presence of health insurance, 53% of stroke victims still experience financial catastrophe, and this was largely due to the levels of co-payments for hospitalisations and treatment. So clearly, health insurance is important in protecting individuals and their households, but it's probably best viewed as part of a multifaceted strategy to extend financial protection and strengthen health systems.
Okay. All right. Thanks for that, Tracy. So one of the aims of our paper was to really try to draw out some of the unique issues, I think, that non-communicable diseases pose in developing policies to strengthen financial protection within developing health systems in low and middle income countries as they progress towards achieving universal health coverage. So we proposed 6 recommendations as part of this work that are really quite critical for developing comprehensive financial protection to address the growing burden of non-communicable diseases, as well as to achieve the first and the third, so that's the poverty-related and the health-related sustainable development goals. And so I'm going to speak today about 2 pressing issues that are really at the heart of those recommendations. So first, we make a strong case for the need for compulsory prepayment of health insurance, likely financed through taxes. And this is because the costs of non-communicable diseases, such as diabetes and heart failure, this is no surprise to people in this room, these are long-term costs, they're often predictable, and as disease progression occurs over time, so too may health service utilization, and so too will the costs associated with health service utilization. There's now, I think it's fair to say, a wealth of evidence to support the fact that voluntary opt-in health insurance schemes are just not well equipped to deal with that sort of circumstance. And they're not equipped to offer effective financial protection under those sorts of circumstances. And the main reason for this is because they suffer from the issue of adverse selection, where essentially the bad risk pushes out the good risk and ultimately undermines the risk pooling objectives of health insurance. So that's one of the main reasons why compulsory prepayment schemes are required. The other is that a compulsory scheme will help to protect individuals against being uninsurable due to pre-existing conditions. For example, having a risk factor may make you not eligible for treatment for the actual NCD treatment that's required down the track. I think this issue of uninsurability as a result of pre-existing conditions is something that, in this setting, people would be very familiar with. It's been hotly debated within the health insurance discussions within this country. So a compulsory tax-based system attempts to break that link between payment and risk and offers the opportunity for a more equitable type of coverage than the voluntary schemes. So in making this recommendation, we acknowledge the challenges that are associated with implementing, ensuring that there are mechanisms in place to collect taxes, particularly from those employed within the informal sector or those who are not employed at all. We also recognize the importance of supplementing these sorts of mechanisms with other more targeted strategies that can address the often substantial health-related non-medical costs that are associated with non-communicable diseases. Tracy mentioned studies that came up in our review where insurance alone was not sufficient to mitigate the impact of the risk of experiencing catastrophic levels of health expenditure. So health insurance for medical expenses alone is not enough. And we drew on examples from Cambodia in the way of health equity funds, which are an example of mechanisms, more targeted mechanisms that have been put in place and trialed to try to really address some of that supplementary care that's required over a long term. So the second issue that's at the heart of the recommendations that we make is the need for prioritizing the elimination of financial barriers to cost-effective treatments for non-communicable diseases in the development of benefit packages. And Dean and Rachel were touching on this earlier today. And this is particularly important for treatments for risk factors. Risk factors for non-communicable diseases. So, for example, hypertension and early screening. Essentially, if you can catch and treat and manage these risk factors early, this will avoid some of the more expensive costs of treating the NCD down the track. And I mean, we discussed kidney disease earlier today. Dialysis, as many know, will not only bankrupt households, it also poses a substantial economic burden on healthcare, on health systems. And so the treatments, ensuring accessibility and an affordable treatment for risk factor, management of risk factors is critically important. So a first important step for actioning this, we argue, is that it requires supporting countries to build capacity to institutionalize a systematic approach to identifying and selecting cost-effective interventions for non-communicable diseases. There are certainly examples to draw from, mostly from high-income countries, like NICE was mentioned earlier from the UK. Australia and Canada have similar systems in place. Thailand, Rachel mentioned earlier, is an example of a middle-income country that has quite successfully implemented sort of an HTA framework for evaluating interventions. But there hasn't yet been the same traction or uptake and implementation of these models within low-income countries, and there is scope for supporting the development of capacity in order to do this within low-income settings, and it's needed. It's important that cost-effective interventions for non-communicable diseases are made available without user fees, particularly amongst the poor. I think Tracy's work really reinforced this link between, first Tracy, number one, this link between non-communicable diseases and socioeconomic status. A lot of the work that was used within the disease control priorities has illustrated this development of cost-effectiveness methods to really showcase financial protection benefits that are important benefits that should be considered alongside cost-effectiveness evidence. So this idea of avoidance of catastrophic health expenditure as well as medical impoverishment. And so there are methods in place to value these outcomes and to consider them alongside the cost-effectiveness, more traditional cost-effectiveness evidence. There's an equity imperative to prioritize interventions that target the poor. And I think we've sort of reinforced that here. So the important take-home message from this paper is that we've argued that the most effective and sustainable means of addressing the microeconomic burden of non-communicable diseases and of promoting universal health coverage is through compulsory prepayment schemes that are potentially financed through tax-based measures. And this needs to be backed by the systematic assessment of systematic use of cost-effectiveness in the design of benefit packages. So ensuring comprehensive financial protection against the growing burden of non-communicable diseases is critical for achieving universal health coverage, as well as for several of the sustainable development goals, as Rachel touched on. But importantly, it's quite an important step in this road towards achieving the global alleviation of poverty. Thank you.
Thank you very much, Bev. Great, thank you. And I think that you can note, moving from the first two papers that we briefly presented, that we are moving towards, okay, what should we do about it? Yeah, we have a pretty good understanding of the problem. We've described connections to SDGs. We've certainly described the connection to poverty, which is an important component. Now what to do about it? And the next papers, including what Tracy and Bev just described, are very much oriented towards, what are the solutions? What actions need to be taken? So I hope that comes through. I'm going to turn next to Annalisa Belloni, who is an author on paper number 3 on price policies, led by Franco Sassi, and just mention that in terms of action, this one not only gets a lot of action. I think, I don't know if Annalisa is going to mention the UK, recent actions in the UK on sugar-sweetened beverage tax that occurred simultaneous almost with the publication of our paper, but there's a lot of attention to this and questions. What should countries do? What can they expect if they do take action on price policies. So Annalisa, please.
Thank you very much, Rachel, and good morning, everybody. So as Rachel said, the paper is looking at pricing policies, which include but are not only taxing policies. Those policies, in fact, include a wide range of tools that allow, make a change to consumption of unhealthy products, for example, tobacco, alcohol, or junk food that, as we know, are main risk factors for many NCDs. We did look at price policies because there is evidence that they are effective in changing consumption behavior, and also have impact on health. But there is also concern around their regressive effect, and in fact, the fact that the financial burden placed by those policies on the poor has been a barrier to the implementation of those policies. And we wanted to assess whether this concern is founded. The focus is on low middle-income countries, but we also include evidence on high-income countries to see whether the results are applicable to a wide range of settings. How we have done it, we have gathered evidence and data, mainly data on consumptions of those products by households at different level of income. So we look at how much those households consume those products, how often they consume those products, and how much do they spend on them. We also gathered some data and evidence on how households, consumers change their behavior after a price change, and also evidence around the wider economic benefits of those policies. What have we found? So first, an overarching finding is that low-income consumers benefit the most on health terms, and this is because of two reasons. They are more price responsive, so they respond most to price changes. And the second reason being the fact that risk factors for NCDs, so they are more exposed to NCDs. On the financial impacts, we found different conclusions according to the three groups of products that we looked at. Alcoholic beverages show a progressive pattern, meaning that households with high level of income are actually consuming more alcohol and spending more on alcohol. So they will pay also disproportionately on alcohol taxes or after price hikes. For tobacco, we see the opposite pattern. In fact, it's usually households in the low-income households that consume tobacco, and also they will spend more on tobacco and taxes. However, the health benefits of reducing tobacco consumption are so large that they will actually benefit in terms of reduction of catastrophic expenditure, or also they will have a gain in labor market outcomes. For example, they will be healthier and so have an increase in productivities or wages. The last group of products we look at, soft drinks and snacks, show different patterns according to the different level of income of countries. In lower income countries, we tend to see progressive patterns like alcohol, where the rich are actually consuming more and paying more for those products. While in higher income countries, we see the opposite. So it are usually low income households who are consuming more and paying more for those products. But looking at the monetary effect involved, this is fairly small. There is evidence that, for example, in the US, the low-income households will pay an extra $4 a year on sugar, sweetened and beverage taxes, and in the UK, this is around £8 per year. So a fairly small amount involved, and this might not justify entirely the concern about the regressive effect of those policies. So overall, we conclude that pricing policies are effective measures, usually sometimes they are underutilized, and we provide some recommendations to governments because it's very important, it is really crucial how the tax is designed, so what's the structure of those taxation, and also when doing an analysis on the regressive impact of those policies to use the right measure, because sometimes different measures provide different results. I think I'll leave it that.
Thank you.
Thanks.
Gracias. Thank you very much, Annalisa. All right, finally, we're going to go to the last paper. Kofi Akwa is a colleague of mine at RTI. Kofi is not a co-author on the paper number 5 here that was led by Melanie Bertram. Melanie and the co-authors could not be here with us. However, Kofi has done the same kind of analysis using the same modeling tools and data input, and we are doing quite a few of these at the country level. So Melanie's paper that's in here is multi-country across different income levels, and you see the results in terms of return on investment. And this was the most important paper for Robert Beaglehole to get in here because he felt that it was crucial to have the investment case, as it's called. You know, how do we speak to the finance ministers about the economic benefits of addressing NCDs? And so we're delighted that Melanie's paper is here. Subsequent to that paper being done, our ability to analyze the costs and benefits has expanded. So it's not, Kofi is going to present a paper from the work that we did in Jamaica that goes beyond cardiovascular disease. The paper in the series is just cardiovascular disease, important and shows high return on investment. Kofi is going to briefly describe what we've done in Jamaica and we're doing in other countries because really countries want to have their story. They want to have their data, their return on investment. So there's not an inconsistency, but it's important to get it at the country level. So Kofi, please.
All right, thank you. And I will stand here so that I can see the slides. So my section focuses on investment cases. And in particular, I'm concerned with 2 main questions. Number 1, why would you want to conduct an investment case? How is an investment case done? And in the end, I'll illustrate with an example of the work that we completed in Jamaica. So why would you want to conduct an investment case? So to answer this question, it's important to take 2 steps back, to think about how economists think about the economic burden of NCDs. And we group these into 2 main types of cost. So the first is indirect, and the second is direct cost. So what do indirect costs refer to? So indirect costs refer to the fact that there are decreases in productivity that arise from NCDs. And there are 3 main reasons why this occurs. The first is that we know from the literature that individuals with NCDs miss days of work. We call this absenteeism. And even if they show up to work, they are unable to work at full capacity or at their full potential. And we call this presenteeism. We also know that there's premature mortality associated with NCDs. And if you think about low and middle income countries, you can imagine the wealth of skills and experience that we lose from people dying prematurely from NCDs. We also have direct cost, which refers to high healthcare expenditure on treatment of NCDs and complications. This has huge burdens on households because you can imagine that funds that would have been saved from avoiding NCDs may perhaps have been used to invest in human capital to go back to school and improve their skill set, and even from the government perspective, that it allows them to divert funds to other development efforts. So this is how we think about the economic burden of NCDs. The good news is that there are solutions. So the WHO NCD Action Plan identified 88 interventions that can allow countries to recover economic benefits that are lost due to NCDs. And these interventions tend to either be clinical, so they occur in the clinical setting, or they tend to be policy instruments at the national level, such as increasing taxation on alcohol and cigarettes. So that's the good news. The slight bad news is that there's nothing like a free lunch. So there's a cost associated with it, right? So when you think about implementing or scaling up these NCD interventions, there are medical and non-medical costs associated with it. And if you think about the medical perspective, you need more personnel, you need more drugs, you need more devices, etc., which all come with a cost. And this allows us to then go to the point, which is, why do we conduct an investment case? So we conduct an investment case in order to answer the question, does the monetary value of these investments and the health gains associated with it exceed the cost? So this is the fundamental question that we try to answer with an investment case. And there are really 5 steps that we undertake with the investment case. The first thing is that we work very closely with the Ministry of Health. We did so in Jamaica, where we interact and find out, of those 88 interventions, what are their priorities? What do they want us to focus on? And then we collect local data, because we want it to be relevant to the country of interest, to calculate what the cost would be from implementing and scaling these interventions. We then use various economic models and the literature to estimate what the health gains would be. We then put a value to these health gains. And then, going back to the previous slide, we can then answer the question, will the health gains from these investments exceed the cost? And the example that I want to show is work that we did in Jamaica. So with the Jamaica investment case, we selected a subset of interventions, and we calculated an economic benefit of $77.1 billion over a span of 15 years, and this is in Jamaican dollars, from the various investments that we decided to prioritize. And we can also break down these total economic benefits into their components. So we can identify what are the benefits that we think will accrue from premature mortality, the benefits that will accrue from presenteeism, i.e. people can now work closer to their full potential, benefits that come from absenteeism, and also the averted direct cost of treatment, because we know that NCDs are quite costly to treat. And what we also do in the investment case is to show these benefits in relation to cost. So you can see over the span of 15 years how these benefits are increasing relative to cost, and you can see that the gap in terms of benefits minus cost are increasing over time. And this is to illustrate the importance of taking a medium-term perspective with these investments. The powerful thing with investment cases is that it allows the Ministry of Health to have the numbers and sort of the economic case to go to the other ministries or the other entities within the government institution to say, this is what we need to scale and implement these interventions, and these are the benefits you can expect within the country. And it's not, if health gains is the most important return that we can think of, but even if you were to take an economic perspective, it is very important to think within the country's plan for economic gains to consider the problem of NCDs. And this is a summary of the kind of work that we do.
Thank you, Kofi. Great. All right. With that, thank you, all the panelists, all the presenters and authors. Let's turn to you and take some questions. This is the Q&A, and then we'll have a stretch break and switch to dessert. But this is quite a lot to chew on, I think, for the main course. So please, yes, please here first and tell us who you are.
Hi, my name is Jihan Do. I'm from South Korea. I'm an international student at University of Pennsylvania. I'm in like health leadership and primary nurse practitioner program. And I'm so happy to be here today, even though this is my final week. So I have a question regarding smoking. So we all know that smoking is one of the greatest, major risk factors of NCDs. And it seems to me that like policymakers or people are reluctant to raise tobacco taxes to me. And even in the United States, it's not really like there is a great, differences between tobacco taxes in different states. And it's true in the worldwide, I think. So what I want to hear from you is that how do you think about raising tobacco taxes? And also if there is any like other cost-effective interventions to prevent, smoking in developed and developing countries.
We'll take a couple of other questions maybe, and then we'll come back to the panel. So over there.
Hi, I'm Emily Mendenhall. I'm an assistant professor of global health at Georgetown University. There are two things that come to mind. I'm an anthropologist, so I study the squishy questions of, what do you experience? How's your life living with diabetes and depression and all these problems that cluster together. So I was wondering if you could speak to two things that are just really powerful dynamic issues in people. I've interviewed people all over the world. Well, one is the complexity of, you've hit, so many issues that come up in my work. It's a brilliant collection of papers you've put together. But one of the things that comes up every time is, okay, I get to the hospital and I can care for one disease and not the other. So this integratedness within the clinic itself, that seems to be such an extraordinary barrier. And wrapped up into that question is how you think about NCDs that are not isolated entities within people or communities or populations. They're very much, I like to use the word syndemic, or integrated into these complex, infectious conditions and environmental factors, that they're just wrapped up in these complex lives people live. They're never isolated. The other issue is trauma that becomes so deeply embodied in people's lives and their metabolic conditions, for example, and their depression and their anxiety. And this is something that is overlooked again and again, the black box of stress that none of us really want to tackle. Can we think about that or even integrate that complexity into these large financial models, because they seem to be really driving a lot of these biological processes? Thank you.
Thanks, Emily. Here down the same row, and then we'll do one more, and then we'll come back to the panel.
Hi, Catherine Taylor from MSH. Thank you to the panelists and Rachel for an amazing presentation today. It's really an exciting discussion. Couple of times we've talked, well, a lot of the times during the course of the panel, we talked about prioritization, policymakers. And we heard your example about the end-stage renal failure in a small island where the economic case was made that this was not an appropriate use of resources, but still went ahead. So do you have any suggestions for those of us working in governance around how we can really move the needle on policies and help policymakers really prioritize for the most cost-effective interventions?
Thanks, Catherine. Christina, was it? One last question, and we'll come back to the panel.
Thank you. This is Christina Ravadan-Deal from the Department of Health and Human Services. So my question relates, it's a larger question, I think, that really touches every single paper, and congratulations to all of you. But I guess, I'm focusing a little bit more on the regulatory measures and particularly taxation on some products. So clearly there's no question that the improvement that we've seen and the decrease on tobacco consumption and the improvement in health, that is clearly, the link is there. And it's not only because of taxation of tobacco, but also because of all of the other measures that we put in, regulatory measures, as well as behavioral campaigns, education, et cetera. It seemed to me, and maybe I did not read your paper as careful as I should have, but it seems that the data is there, certainly for tobacco. It seems we are getting there. For alcohol, but the issue of sugar beverages and junk food, it seems to me that you do have a little bit of evidence regarding consumption, behaviors as far as purchasing, but not so much on the link on health behaviors. And I wonder, as we're thinking about the need of multi-sectorial approaches and the need of engaging really all sectors, whether we are seeing, particularly from UN bodies, a reluctancy to engage some stakeholders, particularly food industry, in this dialogue. And I wonder, and I worried, actually, that if we are focusing so much on this taxation of those products, and perhaps not including the relevant stakeholders in the consumption, in the dialogue, whether by taking these very radical measures, we are excluding a very important stakeholder and interlocutor. And I wonder whether, particularly if we are going into this evidence-based approach, whether, and this goes and links with the first intervention, whether we should start really thinking about more implementation and generating the evidence base, and perhaps in the meanwhile, looking at voluntary measures, for example, of reformulation, and focusing also on alternative issues, addressing the issue of food deserts or affordability of healthy foods, because the reality is that for those poverty issues and poor households, they don't have a choice. And even if you tax it, they're still going to consume those products. And I would like to hear a little bit, your impressions about that. Thank you.
Great, thank you. Great array of questions. So we'll go through those. I think I'm going to speak to the first question a little bit, and Annalisa might want to as well address it. And then whatever questions rang some bells for you, and we'll try to make sure that we cover them all. So thank you. So smoking taxes have been very well proven to change behavior and to improve or to reduce the burden from tobacco-related diseases. And there are something like 37 tobacco-related diseases. I mean, it has huge effects on people's health. And time again, we have seen that raising taxes, and the WHO recommends that taxes should be at least 75, if I remember it right, 75% of the price. And many countries are below that. But when you see countries like France and like the Philippines and others that have raised taxes quickly, dramatically, in large amounts, you see very fast health returns and economic returns. So it is the most cost-effective intervention. But your question is what else to do? Because you're right, in some countries, it's simply not politically feasible, at least not at this time, or it's not going to happen very quickly. So, of course, there is the list of empower interventions that WHO has put together that are part of the Best Buys. And interventions are more effective and forceful if you have that combination of, get me here, and get me here, because then I'm going to really remember. So bans on smoking in public places, plain packaging, limitations on marketing, those things are all good. Not as dramatic, not as immediate as the tax increase, but all good. One of the things that we're doing, and I'll stop after this, is we're working now with the Framework Convention on Tobacco Control to do economic analysis of going beyond the Empower package, because there are other things in countries that either inhibit them from implementing the full set and implementing FCTC fully, even if they are signatories to the treaty, but that they think are important in their country. So working on tobacco production among farmers, and it's actually pretty dangerous work to do to be raising tobacco. There are health harms to the farmers. And there are some countries that actually subsidize tobacco production, but there are countries that want to get their farmers out of it. And so we're working on measuring the economic benefits and costs of that. There's concern, especially when taxes are raised about smuggling. A lot of concern about that from countries, and so we're trying to quantify that. I'd say in general, that concern is overblown. In general, you don't see, unless there's certain conditions being met about sort of the country's borders, enforcement, things like that, you don't see a lot of counterfeit tobacco products for most countries that in a substantial way that come in when you raise taxes. So we're that's very brief, but we're doing this work because the FCTC has not been fully implemented, and we have not yet sort of reached the bounds of where we need to get with tobacco taxes. But I think it's certainly one of the things that we feel, we as sort of a community and the research community feels we've got very good evidence on, and we can take that even further. I'm going to stop. I've talked so much already, but why don't I go down the line, maybe Tracy, starting with you, to pick up on the questions that you'd like to. And if you want a reminder, there's a question, then Emily's question about multimorbidity and integratedness and syndemicity. Catherine's question about moving the needle for prioritization, priority setting. Christina's question, I'm sure nobody has forgotten that one, about SSB and junk food taxes, and what about alternatives and so on. So let me invite panelists one at a time.
Great. So I think, oh good, the mic's on. To start with taxes, and you mentioned that in the States we can't even get from one state to the next. I think we almost have to look at it by communities, because it's not a human right, to smoke, but it's not illegal either. So when we talk about banning products or making a single policy for the U.S., the system's not really in place to ban smoking in cars with children in the back seat, as it is in other nations that have done exactly that. So we don't have the centralized control over our policymaking in the U.S. And we do see where people really resist at first, efforts to curb smoking, similar to motorcycle helmet use, so that, you know, they're the people who enjoy these things, you know, they are a lobbying group, and they're quite passionate about whatever health harming behavior they might engage in. So I think that that's always something that we consider. I work for the Department of Defense now, and there was movement, very loud movement, to try to ban the use of tobacco products while in military uniform. And there was huge outrage, because indeed it's not illegal. You can smoke cigarettes, right? It's not illegal to smoke. They're not prescription drugs. They're available, and they're available for sale. So while everyone was focusing on the bright, shiny object of banning tobacco use while in uniform, what Defense Health Agency leaders did in our case is they produced price equity with the local economy in cigarette sales through the military system. So it was doing what was possible, even though what would be ideal was not possible. And I think that in all communities, there's the need to look at, do we start by banning smoking in bars to protect the health of the bartender? And then do people like that, so that then there's that growth of no smoking zones? So then smoking becomes more and more of a challenge. So taxation works brilliantly, but no one's there yet with the Framework Convention on Tobacco Control. And we've had a lot of time as a globe to work on it. We may be, for the synthesis lady question asker over there, we may be moving down the same pathway in parallel with the mental health community. You know, certainly we didn't include mental health in our sort of heart disease, tobacco-related lung illnesses, and cancers NCD approach. And when we do that, there is a risk. And if you look at what is the most studied non-communicable disease risk factor on the planet, and that my team has, we study obesity all the time because it's easy. But we're counting, but we're not spending time digging into what factors are making that possible. And it's certainly not just the availability of calorie-dense foods. There's more to it than that, certainly. And then, Christina, always, you know, that whole of government, whole of society approach doesn't work if there's parties that we won't talk to. And many of us who have worked on projects that have private sector representatives, there has to be partnership there. And this is unpopular, but I believe that we have to allow them into the room, at least to hear their voice, and not say, because this person pays for you, you're not allowed to talk. You know, and when we make decisions like that, we actually make this journey harder toward creating healthier communities and better policies and regulation. I think that there's several high-profile examples, you know, lately with the alcohol industry and with the tobacco industry, that there's outrage amongst public health practitioners and WHO, frankly, about these issues. And I really think from a small personal perspective, if we can't talk about a whole of government, whole of society approach and exclude the private sector, or at least maybe we don't want to take money from them, but we might need to invite them to the table to talk once in a while, to learn what they're up to and tell them what we're planning as well. And I know that that's not a popular thing to say.
Thank you, Tracy. I'm going to move it on. I'm going to ask people to be fairly quick because I don't want to shut anybody up, but we're over time and we have some hard stops later on. So
sure, no problem.
Quick
I can
responses.
be quick. I can be
Thank
super
you.
quick. I guess I just wanted to pick up on your comment around multimorbidity, essentially is what you're talking about. And thank you very much, because I think it's an absolutely important area it's getting a bit of airtime, but I think it probably needs a bit more, and it definitely makes it difficult for us to be able to value economically what the implications are of multimorbidity. I don't have much more to say to that, but it'd be great to chat with you about it later. In terms of priority setting, I think there are a number of tools that are available to help with priority setting that can be quite formulaic. For instance, multi-criteria decision analysis is one technique that's getting some traction in various countries. to less formulaic, where it's all about deliberative discussions. I think the key to priority setting is the transparency piece. And we need to also recognise that economic inputs, such as cost-effective analyses, are an input, but there are many other factors that are going to come into that decision-making process. And I think that's probably all I need to say about that for now.
Okay, thank you very much for those questions. I might pick up on that, and then I'll come to your question. So I've done some work looking at evaluating priority setting for the health system and non-communicable diseases in Uganda. And I think one of the big messages that came through that work, particularly for the cost effectiveness piece, is they recognize that it is just one input. And in their setting, it's not locally derived evidence. And so the relevance is constantly questioned. And this particular study used qualitative methods so we could delve into these issues and how the decision-making is impacted. And so I think it's promising that there's more of a move to use investment cases and to use locally derived. I mean, we have a ways to go. We have to start with kind of global estimates, but now I think there's more of a push to actually use locally derived evidence to make these cases and to look at cost effectiveness of interventions within particular settings, because even within neighboring countries, some of these estimates actually can be quite different in terms of the cost effectiveness. So it's an input, and to make it relevant, I think there needs to be more of an effort and investment in using local evidence. You're right to point out that I think the funding model within health systems, sort of this vertical approach, has actually transferred into the way we research conditions. And I think it's fair to say that there has really been this kind of really single disease focus in terms of looking at the economic impact of illnesses in particular, and the microeconomic impact, which I think I know that literature most. Recognizing that people don't just have one non-communicable disease. It's more common to have more than one, and particularly when you think about the risk factors. So I think there is now, as Tracy mentioned, more of a push to actually try to look at the multimorbidity within the individual, but more importantly within the household, because we're not living as one person within a household. And I think an example of the way that this might be translating into some of the economic evidence is that there are groups that are now looking at expanding, like the extended cost effectiveness analysis is one extension of cost effectiveness. And there are efforts to expand that even further to look at dynamic models that might actually be able to look at the interplay of costs within the household, how those change over time, particularly as disease burdens decrease, and to be able to account for kind of the life course. And so that's sort of quantitative methods, and I think the qualitative work, of course, needs to supplement that. So, I mean, we're not there yet, but I think the recognition supports the fact that we are going to get there.
Shall I use my mic? Okay,
oh, yeah.
Thanks. I'll pick up the point on SSB taxes and junk food taxes, and thanks for asking that question that allow me to clarify this point. I think you're right, definitely the evidence on tobacco taxation or alcohol taxation is stronger, and we have evidence not only that they reduce consumption, but they also provide health benefits. With SSB and junk food, I think those policies are more recent, so the evidence is growing, and from the real world implementation, we just have evidence on that they are effective in reducing consumption. And thinking about Mexico, recently Catalonia, and other countries have implemented those policies, and we see already a reduction in consumption. But there are modeling studies that shows the health impacts further down the line. I know many policymakers sometimes are reluctant of using modeling studies in health. I don't think it's really justified, but anyway, that's happening. One of the reasons why it is more difficult and the evidence is less strong on soft drinks and junk food is because it's easier to substitute, right? And it's difficult to identify exactly what products to be taxed. You know, for tobacco, it's quite easy. All tobacco products can be taxed. But when it goes to junk food, to decide what's the threshold, what needs to be considered as, a bad product versus a good product, it's a bit more difficult. That's why maybe with SSB, that SSB have been identified as a category to be taxed, and like in 2016, WHO recommended SSB taxes to be implemented in countries, even developing countries. That's because it's easier to identify, and also because with food, there is actually a need as well of eating, while with tobacco we can just say that any use of tobacco is bad, while we cannot say the same for food. But SSB are a bit different because they're considered like empty calories and not really something that we need. Lastly, I would like just to provide the good positive examples that Rachel mentioned at the beginning with the UK recently implemented a soft drink industry levy. The UK government announced this, the introduction of this policy 2 years ago, and the idea was exactly to give some time to industries to reformulate their products. So there were 2 years in which the government had conversation with industries, and this reformulation actually happened, and in fact many industries reformulate their product and lower the sugar content in their product in order for the product to not be taxed, which I think is even very positive. It's just been implemented and is already a very positive result.
Thanks. It's worth mentioning it's a two-tier tax, right,
Yeah.
with a lower tax on the products that have less sugar in them.
Exactly.
So
There is a zero
thoughtful,
tax for-
carefully designed,
Yeah.
which is, I think, what your paper suggests, is that you have to really understand the context and design these things very carefully. Last Kofi, maybe you have something to say about the priority setting question? I thought you might.
Yeah.
and then we'll close.
I have a quick comment on that. So I think our experience with Jamaica speaks a little bit to how we set up priorities with country. And I'll say that the main thing is local engagement. So with the investment case, I think there are two things that I wanted to highlight. The first is that we had a data gathering mission before the analysis. So we went in the country, we spent about 3 to 4 days talking to the different ministries, giving an overview of what we plan to do and how we are setting our priorities. And we also took their feedback in terms of what their priorities are in order to conduct the investment case analysis. And I think what really helped with the analysis that we conducted was that it wasn't just about the analysis or the numbers. So in addition to providing numbers from the economist perspective in the investment case, we also had an institutional context analysis report, and that really focused more on the qualitative side. What are the features of the country, et cetera, that combined with the economic analysis gives perspective. And I think these are the two main things that I wanted to point out in terms of moving the needle on prioritization.
Great, thank you. All right, we're going to close this panel. Thank you, everyone, very much for your presentations. Thank you for your questions. So these are either the people with the sweet tooth that want dessert or the stalwarts. And so thank you for staying. I know it's a long morning, and some of us are so enthusiastic about these things that we don't stop. But this is actually a very exciting panel for me to have here, because they bring a diversity of voices and experience and perspectives. And we're not going to spend a lot of time with presentations now. What we're going to have is a discussion. And I have one question to ask each one of them, and we'll let them answer in turn. And then we're going to turn to you, who are here with us in the room, and there apparently are a stream of questions coming in online that we will turn to as well. So we'll have a dialogue with you and with those people out there in the ether world. So I'm going to first turn to Tom Boyke. Tom is Senior Fellow in Global Health at the Council on Foreign Relations, based here in Washington. Tom did some work, a report in 2014, very influential report looking at NCDs in relation to international relations and foreign policy. I think people are very familiar with his work. Has a background in tobacco control as well, which might be a little bit less familiar. And I want to ask Tom, first of all, what's changed in the NCD agenda since your 2014 report, and in particular, our NCDs, part of our diplomatic and foreign policy thinking, we have a lot of discussion about the health security agenda these days, and one of the questions online asks about that. So I'll give them to you at the same time.
Great. Thank you so much. First of all, congratulations to Rachel and the other authors of these terrific papers. It's a tremendous resource. The other thing I want to say up front is I may need to leave early. It is not my discuss with my other panelists' comments if I stand up and walk out of the door, so please don't take it that way. So let me start a little bit by saying a bit about the environment that we found when we did that task force report in 2014. And it'll be familiar, but I think what most people found around NCDs at the time is that there was little interest among the donor community. It was particularly not seen as something that was compelling, a problem that was urgent, or a problem that was actionable. And frankly, that was true for most of our task force. We really pulled together a group of people who had no experience in NCDs. They had lots of experience in global health or development or trade, but really didn't have a lot of experience. And for us, it was not only a way of getting their input on an agenda that might move forward, but it had a bit of a focus group element to it that was very helpful for thinking about how this issue could be moved forward. And I think part of the reason that we have had trouble is there's been this misperception that NCDs are an unfortunate but inevitable byproduct of development or success in other areas of global health. That it's a problem fundamentally of the less poor instead of the more poor, and a problem of big emerging economies, and that there's no clear role for collective action. So that's what we really tried to focus on, and I'm so pleased to see so many of those issues be taken up in this set of papers. And I think there has been success since 2014 in reframing the NCD agenda, mostly through the drum of evidence like these papers. That there has been more of a focus on the premature mortality and morbidity from NCDs and its fast rise, on poverty and inequity as driving that agenda so that it looks more like other areas of global health, which I think is true. And there's been a lot of focus on what elements of the response to NCDs truly make it actionable. I think the one area, and I'll tie this to my end remarks around where we are on diplomacy and foreign policy, I think we still struggle in focusing on what is the role of collective action in this space. What can donors do or international institutions do versus what needs to be done by national governments? I think what has also changed, other than the success of reframing, is I think there's a broader acceptance that if you are an institution that cares about global health, you need to care about NCDs. I no longer get as many blank looks when I come into rooms and talk about NCDs, so that seems like a positive. There are initiatives that have been started that go beyond the usual suspects in NCDs. So I thought Resolve to Save Lives, Tom Friedman's new initiative, is a very positive development in the sense that it draws funding from the Bill and Melinda Gates Foundation and from the Chan Zuckerberg Initiative, and also focuses on treatment, not just on population-based prevention. So I thought that was very positive. You can look at other initiatives out there like like CHI and its collaboration with the American Cancer Society that I thought had some good elements. In terms of what's been happening in diplomacy and foreign policy, obviously this has been included amongst the Sustainable Development Goals since 2014, so that's a real positive. You see NCDs or drivers of NCDs like child obesity being taken up by the G20. That's new. NCDs have been a topic of conversation in bilateral dialogues for the U.S. government. So in its strategic and economic dialogue with China, you see more discussions around this. So it's entered into health diplomacy. And just this week with the World Bank and IMF meetings, you had Christine Lagarde and Michael Bloomberg sitting down to talk about NCDs. That didn't happen 4 years ago. So that's a real positive. We've seen less action on aid, and I know one of my colleagues on the panel will talk about that, so I won't talk about the numbers. But it's mostly been about integration into existing priorities. How does NCD fit into largely what we're already doing? And I think that's been mostly true. There are some initiatives potentially in the pipeline around cervical cancer that might change that dynamic. We'll see. But it's been mostly about how our programs in early nutrition can also address NCDs, or the PEPFAR program can include a few additional objectives to do more on hypertension. I think the one area we haven't seen any progress on in foreign policy and diplomacy is how to resolve the tensions between our foreign policy interests in trade and commercial objectives and global health. And I think that's a conversation, that was a tension that existed in the last administration. It's not new to this administration, but exists now too. And I think some of the conversations that came up in the last panel about should Heineken be involved with the Global Fund? Should Anheuser-Busch be sponsoring a workshop on violence at the National Academy of Sciences? How do we start to engage these institutions? How to think about taxes? I think that's a conversation we're just starting to have. I think the evidence that was presented in this series is really important. So trying to make sure that that conversation at least has a proper foundation in evidence and data, but it is not alone sufficient. So it's a conversation we continue to need to wrestle with, and it's something really new for global health.
Fantastic, Tom. Thank you. Thank you. Really great sweeping view from 2014 to now as well. So I'm going to turn to the other side of the world from U.S. foreign policy concerns and ask Dr. Srinath Reddy, whom I've always thought of as the world's cardiologist, actually. I like sitting close to him, just in case. So I'm going to ask Dr. Reddy to turn to India, because India is a very important country for many, many reasons. And Dr. Reddy heads the Public Health Foundation of India, so strong public health lens, but historically also strong understanding of where we are globally, and ask, what is India doing on the NCD front, and particularly what can we learn from what India is doing? I know there's a lot of focus on primary health care and district level clinics and so on. What's it telling us that we should or shouldn't do? Your choice, or both, please.
Well, I think India started rather late in terms of recognizing NCDs as a major problem in terms of policy and program attention. And the cue was taken actually from the Millennium Development Goals, where NCDs didn't feature. But there were national programs for cancer and later on for cardiovascular disease and diabetes, which evolved and were integrated, but they were not adequately funded. However, in recent years, there's been a lot of attention on the catastrophic health expenditure and the impoverishing effect of NCDs. And both the central government and the state governments came up with a variety of insurance schemes in order to provide hospitalized care for a number of poor and vulnerable groups. But of course, it was not confined to NCDs, but it could include NCDs in terms of care. But even these did not have the requisite or expected impact on financial protection, because outpatient care and drugs and continued care was not covered, and even the add-on hospital costs did not really provide that kind of relief that was required. So now we have seen new initiatives coming up. Firstly, at the level of primary health care, it's been recognized that we ought to do much more in terms of early detection of hypertension and diabetes and some of the cancers like oral, breast, and cervical. And these have been integrated into the National Health Mission, which hitherto was entirely confined to maternal and child health and some infectious diseases. And the idea is that these frontline health posts, which are what are called health and wellness centers, as they're being called, will now undertake a fair amount of point-of-care diagnostic testing, some early care and appropriate referral, as well as a lot of community-based health promotion activities. And they will then try and contain some of the huge escalating epidemic of non-NCDs at the primary health care level before they require care at secondary and tertiary care levels. But even the insurance schemes are now being revamped to integrate some of the national and state level insurance schemes to provide a much higher level of coverage. This is from $500 per family per year to now about $8,000 per family per year, which is quite a huge leap. However, these schemes only will cover the bottom 40% of the population. That means the poor and the near poor. It doesn't cover a lot of other vulnerable lower and middle class populations. So that is something that needs to be looked into. It still doesn't cover outpatient care and essential drugs on a continuing basis, which accounts for a lot of out-of-pocket expenditure. So that needs to be looked into. Where I believe we have not done adequately, apart from planning the UHC properly, is that we have not used the fiscal interventions as effectively as we should have. Tobacco, for example, the cigarette segment also could do with a larger amount of taxation to fit in with the WHO recommendation of 70% taxes. But it is the oral tobacco and the BDs, which are the more frequently consumed products in the country, which are heavily, exempt, or which are substantially exempt from taxation. And as a result of that, we see that posing a major problem. And that is where the political will is required to correct that particular level of inaction. Even in the other areas, we have not seen as much of a crackdown on, for example, alcohol. And we also have seen some weak attempts at taxing sugar-sweetened beverages. But I believe a lot of policy interventions need to come into play. One area which we have not talked about much is the area of air pollution, which is again a major contributor to NCDs. While some efforts are being made to reduce indoor air pollution through greater availability of liquid petroleum gas, still ambient air pollution remains a major problem, and we now know that it's associated with a high burden of cardiovascular disease apart from respiratory and cancer. So there are a lot of policy interventions which actually ought to take place, which ought to bring about a much greater impact on non-communicable diseases. But at least we see that the policy is now being directed towards NCDs, even though it's a bit of a patchwork quilt. But the fact that now there is a recognition and there is some interest in tackling the problem is a positive sign, and we now need to get the pieces together to make sure that we have an integrated strategy for NCD prevention and control.
Thank you very much. Wonderful. And I always ask him for heart advice whenever I see him. So I learned some things from him this morning. You can talk to him offline about the latest. I'm going to turn now to Osundo Gboji, who is a senior fellow at the Duke Global Health Institute, and who is, I don't know, you wouldn't call yourself a specialist, but he is a specialist in health systems and very much interested in the role of NCDs and NCD integration into health systems, and ask you a very, very broad question about where do NCDs fit into UHC, universal health care?
Thank you very much, Rachel, and congratulations on this excellent work to you and your co-authors. I think it's wonderful that this level of evidence is coming out to the public space and stimulating some of the discussions that should have happened earlier. From the health systems perspective, I guess the short answer to your question will be that I see good prospects for NCDs within the context of UHC, but with the caveat that it depends on the level and the type of engagement that the NCD community actually has with the UHC community and the policymakers at the country level, because many of the decisions that will be made, even though these are global movements, the implementation and the decisions will be made at the country level, and it's important to engage people at that level when you're making those decisions. And so I'd like to think about the key issues. Well, many of them have already been discussed, but I'd like to just highlight two, and I'd like to think about them at two levels. First of all, the coverage, and the second will be the actual implementation. And when it comes to coverage, we've already heard about how important it is to have the essential services that are evidence-based being included in the benefits package. We also, what was not said was how much of those services need to be included in the benefits package, because the reality on the ground is that you cannot pay for everything. And so hard choices have to be made. How they are made at the country level will vary from country to country, and we need to recognize the fact that what works in one country might not work in the other, and that will require a high level of engagement. As much as we would like to believe that these decisions are made based on evidence, a lot of resource allocation decisions are actually political. And there are strong lobbies that are behind every decision. So there will be a lobby for medical equipment makers who would like to see dialysis in the benefits package. There might be another lobby for, and I'm not picking on renal diseases or anything here. This is just an example, for example. And I don't know of any lobby. I'm just using an example, so don't tweet me back. So, but what I'm trying to say here is that there are strong interests to cover certain diseases. And it's natural because people tend to see the world from their own perspective. And if you've been treating renal cases, you've been treating hypertension cases, you've been treating cancer cases, you would like to see your patients get better. Not like you don't care about the other ones, but you're operating from where you sit. And those are questions that or issues that the NCD community needs to begin to address and also engage. Yes, cost-effectiveness analysis are important, but at the country level, we also need to add on top of that the budget impact analysis. How are the different interventions that you have proposed to the government going to impact on the government's budget? Do they have the revenues to actually implement them? They might be cost-effective, but they are not affordable. So those are questions that we need to be talking about. And then when it comes to the actual implementation, there's a lot of talk about universal health coverage, not much about healthcare provision. And as far as NCDs go, provision is really, really important because you might have something covered in the policy or in the plan or in the benefits package, but if the patients do not get the care where they need the care, at the time they need the care, and good quality care, then you haven't really made progress. And the questions around implementation capacity at the country level become more important when you think about NCDs. A lot of the developing countries right now, because historically they've treated infectious diseases and the health systems are designed around providing healthcare, one-off health episodes of care. So you treat someone for malaria, you treat someone for pneumonia, but not really designed around providing continued care. Care that will require retention over long periods of time. By definition, many of the NCDs will require lifelong treatment. And also, what you need to develop to provide care for cancer, radiotherapy, or surgery, or even dialysis is different from what you need to provide services for malaria treatment. And I guess we might learn lessons from the HIV/AIDS community who have scaled up what is a complex healthcare treatment in sub-Saharan Africa and have figured out a way to achieve high levels of retention in care over periods of time. Maybe that's one platform to leverage, and I think some people are already looking at how to integrate NCD care within the HIV/AIDS platform. So those are some of the things that I would say would depend on how the engagement is done that would really see some benefit. It's also important to recognize that as important as NCDs are today, it seems like, and I may be wrong, but it seems like at the country level at least, there is already much more buy-in for universal health coverage. So it will make a lot of sense to actually ride that wave with NCD and have these two communities engage even more and not have them stand separate, advocating for different things, and engage so that NCD is not left behind in the discussions around universal health coverage. And we see that in the SDGs, of course, universal health coverage is what is always talked about. So I will say that there are also some minor issue questions that need to be addressed, like referral systems, logistics, supply chain, counterfeit medications. I mean, if you're being treated for diabetes for life, I mean, you would not want to be treated with counterfeit medications. It'll take a toll. So some other issues like that need to be addressed, and I think they can be, but it will depend on how we engage.
Wonderful. Thank you, Osundu. A lot of food for thought there, and a lot to dig into, which we'll do. I'll let you do in just a moment. We have one more speaker. As we get ready for that, I just want to do a crass commercial plug. You mentioned integration with HIV platforms. There will be a special supplement of the journal AIDS coming out for the International AIDS meeting in July that is all about integration with a lot of the models that have been tried and have been underway for some years in Africa. And we did a paper on the economics of integration. There are lots of good papers in there, so commercial plug coming in July. Coming a little later on this year, we will have a publication on donor funding for NCDs. And some of you in the room who've known me for a long time know that one of the first things I did was, as an economist would tend to do, follow the money. And I wanted to figure out what money there was from donors for NCDs. And I was, at the time, at the Center for Global Development here in Washington, D.C., and published a report back in 2010. We have a new report that will be coming out later this year where we have done, it's a very demanding process. It takes a long time to find this money. But we've done an updated and expanded account of donor assistance for NCDs. And Elizabeth, who worked on that, will give a couple of headlines about it, a couple of highlights of that report, and then you'll have to wait a few more months to see the details. Elizabeth.
Thank you. So as Rachel mentioned, we did a report tracking donor assistance for health that was targeted toward NCDs. And our key finding is that it's about 2.2% of global health funding is going to NCDs. And so that is about $1.1 billion in 2015. The good news is that that number is up. Oh, sorry, it's 2.8%. Sorry about that. Yeah, it's 2.8%. And then the good news is that number is up from 1.5% in 2011. And when we did this study, we looked across multilaterals, bilaterals, foundations, and nonprofits. And of donor assistance for health going to NCDs, about 54% of that funding did come from nonprofits. And then 24% came from multilaterals. So it was in descending order, WHO, IADB, and then with the World Bank. And then that was followed by foundations, and then finally bilaterals. When we looked at what was funded, we looked across both NCDs, the disease categories, as well as risk factors. And I don't believe it would surprise anyone in this room that the single risk factor receiving the largest amount of funding was tobacco use. I will say that, responding to my colleagues, a portion of our study also wanted to delve a little bit deeper into looking at some organizations and understanding what they were funded related to NCDs, as well as why they were perhaps not putting more funding towards NCDs. And one of the very common responses that we did find was that a lot of donors did say that they were already funding NCDs through their existing mechanism or funding categories, such as health system strengthening and primary health care. What else? I will say it is something to note that it was challenging to track donor funding for NCDs, as there wasn't a specific category. And this, largely in part due to efforts by Rachel, has improved. And I believe OECD is introducing a new category for NCDs. So going forward, I believe that evidence will be a little easier to collect, but it is still challenging as you have to delve into many of these programs that address, they're not targeted towards NCDs, but multiple disease areas.
Thank you. Great. So let's turn back to you and hear your thoughts, reactions, questions. We still have our fabulous WANL author team here, although I think Kofi has left. So feel free if you wanted to ask any burning questions to the Lancet authors, but primarily this is a chance to sort of flesh out some of these topics that have been raised by this panel here. So over to you. Tracy. And Mike's coming.
So did you discuss or read about this primary health care funding, thinking that and health system strengthening? Or did you reach out to the donors and ask them what they thought was included? Because for those of us who have worked, I don't know, like places where primary health care was built on that Alma Ata Health for All model, or selective health for all, which would be women of childbearing age and children under the age of 5. Did donors not realize that, you know, if you're a middle-aged woman with diabetes or a bricklayer who smokes, that that's not the health care that's being part of the universal coverage or that's available in the health system or the primary? I mean, was there any sense amongst donors that that's not what they're getting with their health system strengthening dollars?
Elizabeth, you might have something, and others, Jonathan, others might also have something to respond on that.
I mean, I can answer that the way that we heard that directly from donors. So that wasn't what we were reading. That was when we went to donors and asked, can we, you know, for numbers on funding for NCDs, a lot of what we were receiving was programming, targeting health system strengthening, and PHC, and they, you know, weren't able, they said it's all in there and couldn't pull out specific numbers.
So they think they're good. But we know that that's not what's being delivered, that if you've got hypertension, there's no community health worker who's helping you diagnose that and manage that condition. And your essential service package of drugs may not include your hypertension drug. I mean, so that might be that last mile with the donor community. I don't know, is it different in India these days, Srinath?
Well, India is less donor dependent now. And therefore, much of the policy making is now dependent on what the national priorities are. And the way primary healthcare is being restructured now, it's yet to become a reality, but at least in terms of the design stage, it is suggested that non-physician healthcare providers, community health workers, as well as mid-level health workers at the frontline health posts will actually have an opportunity for opportunistic screening, early detection of hypertension and diabetes. Essential drugs and diagnostics would be provided free of cost at these centers, and appropriate referral linkages would be provided upstream. And it is expected that as a part of their health promotion activities, they would also not only educate the community, but also minimize the missed opportunities for smoking cessation, for example. So things like these are being actually built in, but one of the major problems is we still are very short of a health workforce. We are talking about depending a lot on technology to bridge some of that, but technology can't take care of everything. You do need health workers at the front line, and that's where we need to pay more attention to. But certainly, I think in the concept of comprehensive primary health care, which becomes an integral part of UHC framework, these are elements that are to be addressed and are being addressed.
Just to add briefly to that, obviously, the donor funding for global health, let alone for NCDs, is but a tiny fraction of what countries spend on health. And increasingly, of course, that's going to be more the case as donors pull back, as they reallocate. So there's a very legitimate discussion to be had about what is the donor role here. And I want to turn to Tom before he has to run, because you brought up collective action. And I think that one might be one of the interesting, you may have other things to say, but maybe about Tom Frieden's resolve, which is looking at treatment, as you mentioned. But, maybe a little bit more thought about, if donors are interested, and there are many that are, what is the proper role from where we're sitting anyway?
Great. I think historically the way people have thought about collective action is with the focus on two elements. The first is global public goods, so things that are shared resources effectively. And there on NCDs, there are many. I think there's the issue of pooled procurement, particularly on the treatment side. It seems like an obvious category, and I know that's something that Tom and his team are looking at. There's research and development. I think one of the things you also heard about very often in the early days and still do is, well, why fund NCDs when there's this large pharmaceutical industry that's funding research into these diseases? And of course, the reality is the technologies they're developing, most of them are not appropriate to low resource, low infrastructure settings. So there's a research and development agenda there as well. I also think in general, from thinking of a global public good context, we focus a lot in the NCD community, and I think we've struggled with this, on trying to prioritize the what, which diseases to focus on and which interventions to focus on, as opposed to the how, which is either through technical assistance or having access to low-cost capital for countries to make these investments. And one of the things I would like to see coming out of 2018 is more focus on the how as opposed to the what, because I think it's an area without a large donor to prioritize the what, we're never going to decide as a community. It's just not going to happen. And I'd rather see a greater focus on the how so that countries can make these decisions themselves. I do want to say, and I know Rachel believes this too, but there's going to be a core group of 30 to 40 countries that will remain aid dependent for some time. And donors, of course, have a role to play on NCDs in those countries as well. To put a plug in for a different paper, we did a paper in Health Affairs in November that looked at the countries that are expected to have the largest increase in NCDs, and we did a preparedness index assessing how prepared those countries are, looking at your WHO health system building block indicators. And what we found is it's by and large low-income countries that are both expected to have the largest increase, but also by far the least prepared. So to give you a sense of that, Ethiopia is expected to go from having 18% of its health burden be attributable to NCDs to having 2/3 of its health burden be attributable to NCDs in 50 years. That's 3 or 4 times as fast of a transition as you saw in wealthy countries. Bangladesh will go from having 28% of its burden be attributable to NCDs to 82%, which is equivalent to a high-income nation, and they'll do that in 50 years. So there's going to be a role, particularly for the poorer countries there, thinking about how donors can, obviously that's still going to be a problem that government needs to take on itself, but how we can best enable and support those governments in doing that.
Thank you. And if you have 1 more minute to spend with us, I don't know if you do. There's a question online. I've been neglecting the online group, and I do want to get back to you in the room, but about, and it's from CDC, I'll name it, about global health security and whether there's a role. I mean, this person thinks that NCDs have to be part of the global health security discussion. Tracy may have something to say after, but Tom, if you want to have a reflection on that.
Sure. I mean, I think they're largely, in some ways, being driven by the same things, and that you're largely talking about health problems that are being driven by urbanization, by a legacy of very vertical approaches to diseases that didn't build broader health systems. So global health security has not historically been the focus of our aid. Most people would think naturally, it's about protecting us from direct health threats, but historically it's been a minority. It's received relatively little internationally, and that's certainly been true for NCDs. And what you find is the same dynamic of countries that are achieving really good outcomes on the diseases that have been the target of global health initiatives. So AIDS, TB, malaria, childhood immunizations do really have done well on those metrics, but have fallen down in the face of an emerging infectious disease event. They're also falling down on NCDs because the health system doesn't extend to that. So I think they have that link. And to the extent we're talking about building capable health systems to address those problems, you can make that at a fairly general level. You can make that link that building those capable health systems will help with both agendas. I'm not sure there's that much more to the overlap. Obviously, it's Tom Frieden's resolve to save lives, if I can plug it for one more time, is looking at both of those issues. And I think he's more or less admitted publicly that other than the broad health system component to it, really linking them together and some of the same drivers, it's not necessarily that the same interventions are going to produce progress on both.
Thanks, Tom. Back to you. Questions, comments? Comments are welcome. Not speeches, but comments. Yes. Thank you so much, Tom. Yeah, he has his own event to run, so he's got to run. Yes, Tracy. I mean, Bev, sorry.
Okay. Yeah, it's confusing. So, I mean, I think Dean raised this issue about the
unaffordability of the full NCD package for low-income countries, many middle-income countries. Am I not speaking to this? Sorry. So Dean raised the issue earlier about the unaffordability for many countries of the full NCD package. I think Rachel, in your paper, you mentioned the cost of the SDG, how much health systems or governments should pay to fund SDGs. And there isn't that sort of revenue coming in. I think we can expect donors to play a part. But I wonder if the panel have ideas or experience with innovative models or countries that have been able to increase national investment in health or across sectors to try to meet some of this. The money, part of it has to come from donors, but there is a responsibility within countries to be able to pay for this as well. And are some countries doing well and providing lessons to learn from?
Great question. Yeah, thank you. Asundu, can we start with you? If you want to comment? And anybody else?
So, in terms of international donor assistance for health in general, it's not rising as fast as we would want it to rise to deal with the issues, the health challenges that different countries are facing. In fact, for some diseases, they have flatlined and are now going down. For example, recent replenishment for HIV/AIDS is actually on the decrease. And what we're seeing in related work is that most of the monies that will be coming in from domestic resource mobilization. And in general, countries, as they transition from low income to middle income, lower middle income, and upper middle income, tend to allocate more of their resources, a larger percentage of their GDP to health. Some people have tried to use earmarks, which some others don't like, and then some people have tried to advocate in different ways. But in general, there's a trend of increased allocation to health from economic growth. And also budgetary public spending on health also increases. It's not automatic. Some things happen for those things to increase. But in general, people tend to pay for more health services the richer they get. So I think the prospects, long-term prospects, will come from increasing domestic resource mobilization. And it's not clear how that will happen for all countries because situations are different for each country. Some of the work we're doing in Ethiopia and also in India, which India can be regarded as multiple countries within one country, right? Because what happens in one state is different from another. You see that the approaches that work in one do not work in the other. So sometimes you might find you could do a fiscal space analysis and find out that you can free up resources from some certain areas. And sometimes you just see that maybe advocacy to just increase the pot. But talking to the health minister and the health minister speaking the language of the finance minister is one key intervention that happens. And I like the investment case that you have here because it makes the work of the health minister easier when he goes to make that economic argument to a finance minister who has competing requests from other sectors. So I think most of the money will come from domestic. I mean, in the long term, there's just no way we can meet the health challenges without stimulating more resources from domestic. And then there are new players on the donor scene. China just recently launched its foreign aid, equivalent of USAID. And the private philanthropies are also increasing. So things might change, but yeah.
Thanks. So there's not enough money. It can be expensive. Limited role for donors. Elizabeth?
Sure. I would just build a little bit on what he said, and that's I work a lot in mobilizing domestic resources outside of NCDs for health in general and for other disease areas. And I think that one of the most critical pieces is this local evidence and production of local, the investment cases and, being able to continually track how much funding is going to NCDs in countries. I think that's really critical. I would also say that when countries are, moving to national insurance type programming and looking at essential benefit packages, there's generally a phased approach. And so I think that, they typically start in most critical areas and covering most critical treatment and care, but then it does move up. And so I think continuing the NCD conversation as countries continue to develop that essential benefit package. The other thing I would say, building again on what he said, is that I think, in working with countries and supporting sort of advocacy for additional funding, one thing that becomes pretty clear is that it's very difficult to convince countries to allocate programming away from one disease area to another, and that's very unlikely. So I think that the focus is rather on new money coming into the health sector or into the overall government budget, and then using prioritization tools to grab some of that money. And I think, when you look at some of these policy interventions that raise revenues, such as taxation, there's more of an argument to be made for why NCDs should be grabbing more of that funding.
Do you want to say anything about it?
Well, clearly we do need a greater allocation to health, but we also need more allocative and utilization efficiencies in order to get better results for the money invested. But one of the areas where we can actually move governments, such as the Indian government, towards greater attention to health financing is that we are now wedded to realization of the SDG targets. So if you're talking about reduction of premature mortality under the age of 70 years, and a third of mortality reduction by 2030. And India has a very high burden of premature mortality due to NCDs. Then we have to work out what package can actually deliver that result. And then work backwards to say, okay, these are the most cost-effective or extended cost-effectiveness analysis, if you please. And then say that these are the kind of packages that need to be implemented, and this is what it will cost. And then see how they can be integrated at various levels of primary, secondary, and tertiary care into the universal health coverage program. So holding the government accountable for achieving their commitments is going to be critical. Otherwise, we will not be able to make that argument very clearly. Secondly, of course, we do need much better efficient delivery of health services to convince finance ministers that the money that they're allocating is being adequately spent and well spent. And that actually imposes upon the health system a greater responsibility as well.
Great, thank you. Yes, in the back, please. I think we can take this and one more question, perhaps.
Yes, so my question is Deanna Vaca with the American Heart Association. So knowing and hearing these wonderful presentations and the studies that enlighten essentially our argument, what would be some pearls of wisdom that you would give us as advocates around looking at the high-level meeting? What can we expect? What do we need to continue to push for? What is like the ideal desired outcome? Because September's just around the corner.
That is a great question. And I think that's the, elevator speech question. And we all should have that ready to roll. I think I'm still working on mine, but from the work that we've done for the Lancet, I'll just take the first stab and come to others as well, because I think that there are different ways that we can make this case, as it were, depending on who we're talking to. So, what I do best is to be able to say that, NCDs are a key part of development, that we have demonstrated that the economic benefits exceed the costs in the near term, and more so even in the long term, that there are cost-effective and affordable prevention and treatment things that we can do, and that countries need to do their prioritization. We had a meeting yesterday, and we're preparing a paper for the Alma Ata meeting, and we were talking about the fact that for some cancers, cervical cancer, you can achieve coverage of HPV vaccination such that countries can envision eliminating cervical cancer, or virtually so. These are some of the things that we need to get across, that it can be done. It has been done in many places. It's not always in the United States. We're not doing so well on some of those things. But it can be done in many places. And that overall, and we see this from the investment cases, that the largest loss comes from the premature mortality and absenteeism and presenteeism. Yeah, the direct medical costs are pretty severe and cause the impoverishment that we've demonstrated, but your development depends on being able to keep people healthy and have long, healthy lives, even past age 70, without extended costly morbidity, which again is something the U.S. hasn't learned the lesson of. So that's not 3 minutes, is it, at all? But that's something I take out of our series. Srinath, you probably do this every single day.
I would first of all recognize that this is a meeting taking place in New York and not in Geneva. I'm not addressing the health ministers. I'm actually addressing heads of state. Therefore, my argument is going to be extending global health security to global economic security. In a world which is increasingly challenged by rising healthcare costs and also is being threatened by a possible recession, I would argue that NCDs, if neglected, will create unstable labor markets as well as consumer markets. Labor market, the loss of productivity has been demonstrated, but in a globalized economy where people are actually investing in other countries, obviously if I'm a Western investor investing in India or China, I would not like to see the workforce unhealthy and die in their middle age, lose skilled workers because of NCDs, which are eminently preventable or treatable. But if I was also focusing as a trader in eyeing the large growing middle class in India and China to sell my consumer products to, I would be concerned that they're spending more on their health care, purchasing health care, rather than purchasing my products. Therefore, for stabilization of global economy, for stabilizing both the labor and the consumer market, NCDs need to be tackled with political will.
See why heads of state listen to him. Elizabeth, if you only if you want to. Sundu, do you want to comment?
I would just add that sometimes you might get the pushback, or some people don't like the term NCDs. It would be nice for you to be prepared to deal with the diseases on their own and have numbers to support that. I don't have anything more to add to what Srinath just said, because that's a very powerful argument to the heads of state. But I would like us to remember that when we're talking to health ministers, the language we use is different from the language we use talking to finance ministers and also to to heads of state. And I think that was very, very perfect. We should not transfer our health speech to talk to the heads of state. They probably don't care or may not be willing to, they don't have the skills to really understand it, or may not be willing to make that link between their politics and what you're talking about. So just thinking about the context in which you're delivering that will be good, and looking at the diseases themselves. I know in the meeting yesterday, there was some pushback about the term NCDs, and it's growing. People want to know the disease and not just the larger umbrella term. So be prepared for that and have a ready response.
Super, great. Last question, then we'll wrap up. Did you want to ask your question? Yes.
Hi, good morning. Thank you very much. My name is Evelyn Tomaszewski. I'm a consultant. Our speaker earlier mentioned the Forum on Global Violence Prevention, which had me thinking, got me thinking about some of the work that's been done around looking at the economic and social costs of violence. And earlier panel Kofi spoke about the indirect costs, and speaking about mental health and neuropsychiatric issues and psychosocial care. And that there is much evidence about the impact of mental health and substance abuse on the community, on the individual, on economies. And I was wondering what the future might hold in terms of looking at mental health and behavioral health as part of the NCD rubric.
Great question. I'll say something, but then very briefly, there was a mental health investment case published I think it was Lancet Global Health, maybe late last year by Dan Chisholm and others, which did the economic modeling. It's fairly narrow. We're doing some more of that by country in the countries that we're working in and doing these investment cases. We're also, and this is really more, I think, to your point about sort of bringing together some research agendas and research evidence, we're doing an adolescent investment case where I really am struggling to figure out how to quantify the life impacts when adolescents engage in very risky behavior. So it could be, it could be violence, it could be HIV risk, but in this case we're looking at the alcohol, tobacco, other NCD-related risks. And it's very hard to find the evidence that allows us to kind of quantify those long-term impacts on, say, household formation, education, employment. I think in the US we've got a pretty good handle on a lot of that, but internationally less so. So that's my short little experience with it. But Srinath or anybody else?
Well, I think the omission of mental health in the NCD declaration of 2011 was actually corrected even while the final declaration was being passed because of India's initiative, actually. And later on, many people now actually couple NCDs and mental health together, even in a health system approach. And even in terms of advocacy, the NCD Alliance, which started off with 4 organizations, now includes mental health related organizations. So I think this is actually now an integrated approach that's advancing across the world. Of course, some of the approaches would be different in terms of what specific interventions are needed, but I think not only because of the intersect between mental health and NCDs, but also because of chronic continuous care that's required, communitization rather than institutional care. All of these elements actually fit very well into a universal health coverage framework, which is now being revised.
Great, and with that, okay. With that, I'm going to close this panel. I'm going to close the session, the whole morning. I won't even have a closing statement because what Asundu and Srinath said in response to Deanna's question is perfect. I don't think we need to say anything more except to thank you very much for being with us, for staying with us, and for being interested in this agenda.